Hi everyone, welcome to my theatre. In this movie, we will learn about intraocular pressure, which is otherwise known as IOP. So why should we learn intraocular pressure? Because intraocular pressure is a very important thing in glaucoma. Why is it important? Because it is in fact the most important risk factor and the only modifiable risk factor. Intraocular pressure is the only modifiable risk factor in glaucoma, because of which it is very important. Well, when we talk about the definition of glaucoma, it is the optic disc changes and the corresponding visual field changes. Intraocular pressure is no more a part of the definition, but it is the closest friend of the definition, which means the intraocular pressure gives us a lot of information which helps us in confirming the diagnosis and also knowing the type of glaucoma. That's why, being the closest friend of the definition, being the most important risk factor, being the only modifiable risk factor, it's very important that we know what intraocular pressure is and how do we measure it and things related to that. Fine. That's why we should know about the intraocular pressure. So what is intraocular pressure? Intraocular pressure is the pressure inside the eye because of the circulation of the aqueous humor. The aqueous humor is the fluid which is present in the anterior segment, and this aqueous humor is produced, circulated and drained out, and this circulation maintains the anterior chamber, and because of that we get a pressure which is known as the intraocular pressure. And normally this intraocular pressure is somewhere around 16 with plus minus 2 standard deviation, with the higher normal limit of around 21. And this intraocular pressure also shows a diurnal variation, which means it is highest when we get up early in the morning and it goes down as the day passes, with a diurnal variation which can be up to 8 millimeter of mercury. This intraocular pressure can show a diurnal variation of up to 8 millimeter of mercury. Fine. So this is about the intraocular pressure. And briefly about the circulation, the drainage, we know that the ciliary body has this pars plicata and the pars plana. So this is the pars plicata of the ciliary body. This pars plicata, the finger-like projections, and this pars plicata of the ciliary body is the one which secretes the aqueous humor, and this aqueous humor then comes to the posterior chamber, and through the posterior chamber, through the pupil, it goes to the anterior chamber and then maintains the chamber, and finally it gets drained out of the eye. When we talk about being drained out, it gets drained out through two mechanisms. One is the trabecular pathway, which is more common. Now we say that it is 90%, but now few studies say that it is less than that, which can be around 55 to 60%. And the UV scleral pathway is the rest, which is somewhere between 10 to 40%. And in trabecular pathway, the aqueous which is formed comes to the anterior chamber and moves out through the trabecular meshwork, whereas in UV scleral pathway, the aqueous which is secreted, instead of coming out through the trabecular meshwork, it moves into the suprachoroidal space and then it moves into the sclera and orbit. So briefly knowing about the circulation of the aqueous humor. Now let's know, now that we knew what intraocular pressure is and we also knew how the aqueous is being formed and drained, now let us know about the kinds of tonometry. What does it mean? It means how do we check the intraocular pressure? Because the final information that we need is how much is the intraocular pressure, because if the intraocular pressure is low or high, accordingly we will decide about the type of glaucoma. So to measure the intraocular pressure, we have so many techniques which has come up till date, and broadly we can divide those techniques into the direct method and the indirect method. What is direct method? Direct method means when we are putting a needle inside the eye and measuring the intraocular pressure. That is a direct method. Just put a needle and check the intraocular pressure. And that direct method of measuring the intraocular pressure is known as manometry, because we are putting the needle, attaching that to a mercury, and we are checking the intraocular pressure. So that's why this technique is actually not a practical method. This has never been done in human. It has been done only in experimental animal, and this is not what is being done actually. Even though we can get a very accurate result, but it's not feasible to prick the patient's eye every time the patient visits the eye clinic. If we do so, then the patient will stop going to the eye clinics. So it's not a practical method at all. So since it's not a practical method, we thought of taking the intraocular pressure with some indirect means. And what are those indirect means? Well, when we take the intraocular pressure indirectly, we call it tonometry. Direct measurement of intraocular pressure is known as manometry, and indirect way of measuring the intraocular pressure is known as tonometry. Now, what is tonometry? There are many kinds of tonometry. How does tonometry work? It works on many principles. Well, the most popular principle on which the tonometer works is the applanation tonometry, which we will be learning how it works. We will be learning in very detail because that is the most important principle. The second principle is the indentation principle. Okay, applanation principle means what? It checks the pressure by flattening the cornea, because applanate means flatten. It checks the pressure by flattening the cornea. Indentation checks the pressure by depressing the cornea. There are few tonometers which work on the principle of both applanation and indentation. That is the third. Then there are few tonometers which work on the concept of rebound technology. Just because of the rebound, the amount of rebound will speak about the intraocular pressure. Few are based on the contour change technology, which means the tonometer will change its shape depending upon the shape of the cornea. And there is another concept which is the diatom tonometer, which is same as applanation, but it is transpalpebral. And the final is your OCT tonometry, which is under research. Okay, so we have the direct method, which is manometry, and as I said, it is not a it is I mean, it gives accurate results. It gives us accurate results, but it's not a practical method. It's not possible. So it is done in experimental animal. Only in experiment we have done it. And when we talk about the indirect method can be as I said, it can be applanation, it can be indentation, it can be a combination of applanation and indentation, or it can work on the rebound technology, contour matching, diatom, or OCT tonometry. Applanation, well, we have a whole list of applanation tonometers which we will be learning. Among the indentation, the popular one is COS, which is used in most of the places, in most of the peripheral centers, and in fact even in most of the medical colleges in India. The applanation plus indentation is the tonometer works, tonopen works with this. In rebound, we have the eye care home tonometer for self-assessment. In contour matching, we have the Pascal tonometer, and transpalpebral, we have the diatom transpalpebral tonometer, and OCT tonometry, which is completely under research. Fine. So first let us learn the indentation tonometry. Now, as I was saying, the applanation means flattening. So this is applanation tonometry, and this is indentation tonometry, because it creates a depression. That is the difference between the concept of applanation and indentation. So now first we will discuss about the indentation tonometry. So from this picture, we understand that this is a COS tonometer, which works on the principle of indentation tonometry. So what do? We ask the patient to lie down on a bed, and then we put some anesthetic agent, and we take this indentation tonometer and put it on the patient's cornea. And depending upon where the scale is, we get the reading of the IOP. But depending upon how much we get, we match it with a nomogram which works for this tonometer, and depending upon the results of the nomogram, we say that the intraocular pressure is this much. Fine. So this is the concept of indentation tonometry. So now what is the advantage? Of course, the advantage is that it can be done in patients who are having nystagmus, and it can be done in patients who cannot get up, who are sleeping. So I mean, who cannot who cannot sit properly in the slit lamp. In those patients, we can do. Sometimes it is also helpful in scarred corneas where other things are not helpful. But the disadvantage of this tonometer is that if the patient has some hunchback and the patient cannot sleep, we can't take the reading. And the second disadvantage is that if the ocular rigidity can affect the finding. If the ocular rigidity is less, then just by pressing, the aqueous will be drained out and there will be an unnecessary low recording of IOP. And if the ocular rigidity is more, then there can be a false high reading of IOP. And there is no correction factor for ocular rigidity which is being done in this tonometer. So it is old, but yet in some places it is still in practice. That's why we need to know how it looks like and how it is done. And this is a very favorite question in the practical exam of the examiners also. Fine. Next, let's come to the applanation tonometry. Applanation tonometry is the tonometry which is in practice today, because the applanation tonometry is the gold standard tonometry. In applanation tonometry, we have many. The gold standard among the applanation tonometers is the Goldmann applanation tonometer. The Goldmann applanation tonometer is the best and the gold standard, and you will have to know A to Z about the Goldmann applanation tonometer because that's very important for you. Apart from Goldmann applanation, the Goldmann applanation tonometer has a brother whose name is Perkins tonometer, because they work completely in a similar way. Apart from the fact that the Goldmann applanation tonometer patient has, in the Goldmann applanation, the patient will have to sit in the slit lamp, whereas in Perkins tonometer, the patient can be examined even in the bedside without the slit lamp. And they have another brother which is your Drager tonometer, and that also is similar to both of them, but there is slight difference in the prism design. In the design of the instrument, there is some difference because Goldmann and Perkins are completely same, apart from the fact that the Goldmann is in the slit lamp and Perkins is handheld. But the Drager has a little difference in the way it is being made. The prisms inside it are a bit different. Now, these three are brothers. Now, again, in applanation, we have two more brothers. One is the pulsar and another one is the ocular response analyzer. Why? Why are they brothers? Because they belong to the category of non-contact tonometer. The pulsar as well as the ocular response analyzer, they check the intraocular pressure without contact with the eye. That's why they belong to one category. And when we talk about pulsar, which is NCT, non-contact tonometry, it is seen in many places, but it's almost a screening tool because the results which we get are not very accurate. But when we talk about the ocular response analyzer, that along with the intraocular pressure also takes care of the corneal hysteresis, corneal biomechanics and a lot of things and gives an accurate result. So among this pulsar and the ocular response analyzer, pulsar is more used, but it is more for screening, and this ocular response analyzer is less used, but it gives way more accurate results. Again, the third set of brothers are the Maklakov and the Tonopin. Why are they brothers? Because they work on the principle of variable area tonometer. Rest all are variable force tonometer except the last two which work on variable area tonometer. That's why. But the Maklakov is completely of historical importance, and Tonopin is a very easy tool which goes and measures the IOP. Okay. So let us just know the important points. Gold, when we talk about Goldmann, it is the gold standard tonometer. And as I said, we have to know everything about this because this is what we use in everyday glaucoma clinic. We may not use it in comprehensive clinic. In comprehensive clinic, we may screen the patients with a non-contact pulse air tonometer. But when it comes to glaucoma clinic or for any patient where there is a suspicion of glaucoma, it is the Goldmann applanation tonometer, which is the gold standard, which is needed for assessment of intraocular pressure. So basically that this is the gold standard tonometer, and but it is mounted in the slit lamp. And its brother Perkins, when we talk about its brother, then it is handheld. It is a handheld tonometer. And when we talk about the Drager, it is the same concept, three of them the same concept, but it has different design. The prisms present in the Drager are different, but otherwise all the three are same. These two are completely same. Fine. Next, pulsar and ocular response analyzer. Both are non-contact tonometer. Sorry. Both are non-contact tonometer. And just because both are non-contact tonometer, we will not transmit any infection. Infection transmission doesn't happen. And this pulsar is a screening tool and this is a more confirmatory. Okay, the ocular response is more confirmatory. And Maklakoff is of historical importance, so we will not give much importance to that. So now, since we are discussing about the applanation tonometers, we will be coming to the Goldman applanation tonometer. So what is the principle of Goldman applanation tonometer? It's a constant area variable force tonometer. Okay, and we have understood that when we talk about the applanation tonometer, it measures the intraocular pressure by flattening. Fine. So this is how the tonometer looks like, and this is the prototype of constant area tonometer. And then now let us know how it checks the pressure. Let us just go into a little bit of physics. It's easy, not that difficult, little bit. I mean, just use your brain a little bit and it should be fine. So basically now we say that we will exert force in the cornea and that will tell us the pressure. Why? Because pressure is equal to force by area. It's simple. Pressure is equal to force by area. So how will we get the pressure? If we know the amount of force that we are giving and if we know about the area on which we are giving, these two things will give us the information about the pressure. So we will give a particular amount of force on a particular area and we'll flatten the cornea and that will tell us about the pressure. So that is what the applanation tonometry is based on, which is known as the Imbert-Fix law. But it is not this simple. Certain complexities entered into it. And because of entering of certain complexities, the formula was modified a bit. So now you will ask, what are those complexities? The complexities lie in the fact that when we are talking about the pressure, then it's not only the, when we are talking about the pressure is equal to force by area, then the pressure that we get is being diluted by something else and the pressure inside is being modified by something else and the force which we apply is also being modified by something else, which means there are some factors which are actually changing the force as well as the pressure, because there is some pressure which is present inside which we are not taking into calculation and there is some force which is present outside which we are not taking into calculation while we are measuring, and they are different from each other. So so we will think that the IOP is 15, but the IOP is actually not 15. Maybe some other factor has modified it, which means we will have to do some correction to really get the intraocular pressure. So what are those forces which are modifying this? When we talk about the pressure, when we talk about the force we are giving, so this is the force we are giving. When we talk about the force we are giving, it is not only the force we are giving, but it is also the surface tension of the tear film which constantly acts on the cornea. So it is the force given by us and the surface tension which is S of the tear film. So it is the force which is given by us along with the surface tension of the tear film. And now, is there any force which is coming from this side? Yes. What is that force? First force is the intraocular pressure into area, the force, and there is a force which is coming and that is the corneal rigidity. This is the corneal rigidity, which means from outside there is another force which is acting, which is the surface tension, and from inside there is another force which is acting, which is the corneal rigidity. So this surface tension and corneal rigidity, they are actually creating a screw, like they're actually misguiding us, they're actually making the equation difficult. So now the scientists thought that we have to do something where we can equalize them and we can just remove them from the equation. So to remove them from the equation, what the scientists did is that they thought that we will work on the area. So to modify the equation, so we need pressure is equal to force by area and we don't need anything else. So they thought that let us modify this area so that this S and B will be equal to each other and they will cancel each other and go away from the equation. So they worked on this area and they said that if the area where we are touching the cornea is 7.35 millimeter square and the diameter is 3.06 millimeter, then this S and B will cancel each other. They worked, obviously, why would we invite unnecessary complexities? So the scientists thought that let us not invite unnecessary complexities of this surface tension and corneal rigidity and let us make it simple. And just to make it simple, they made the applanation surface the area to 7.35 millimeter square and the diameter to 3.06 millimeter. And by doing these two things, they modified the equation, and because of the modification, again it became simple, which is pressure is equal to force by area, taking into account that the area is this much. Fine. So this is the first one was the Imbert-Fix law, and this is the modified Imbert-Fix law. Now we know, we want the pressure, we know the area, and now we have to know the force, right? We have to know the force. We have to know the force, which means we have to know how much force is required to flatten the cornea, because that will again, since everything is now cancelled, we know the area, we just have to know the force. The moment we know how much force we are exerting, which is needed to flatten the cornea, then we can easily calculate the pressure. So now, how do we know the force? For example, there are 10 people in a room. Somebody will go and push the applanation completely into the eye in a way that the applanation will come out of the cerebrum. And somebody will go and touch the applanation like a flower. So, which means one person will give a huge amount of pressure, one person will give a little amount of pressure of force. So, how will we know that the force that we are applying is actually the force that is needed to applanate the cornea? Which means we have to have a standardization which will tell us that A is applying same pressure as B is applying same pressure as C. We have to know that everybody is applying the same amount of force, so that the pressure which we get is actually the same even if different people are doing the measurement. Did you get the point? What I am trying to say is pressure is equal to force by area. Now this area is fixed for everyone because it is the instrument area. The instrument is made in a way that the area is 7.35 millimeter square, where from wherever you buy applanation, whether it be US, whether it be UK, whether it be India, if you buy an applanation, then the area is going to be 7.35 millimeter square, the diameter is going to be 3.06. But as I said, how do we know that somebody sitting in US is exerting the same amount of pressure as somebody sitting in UK, as somebody sitting in India? How do we know that everybody is exerting the same amount of force? So to know that everybody is exerting the same amount of force and to ensure that we have increased sensitivity and specificity, scientists thought that we should know, there should be something which speaks us and tell us that yes, this is the amount of force you have to exert. You can't exert any force which is beyond it. You can't exert any force which is less than it to get a measurement, right? So to know that we are exerting the right amount of force, the scientists designed the applanation tonometer in a way that they inserted two prisms inside it. And because of insertion of two prisms inside it, we started getting Myers, which means, okay, I will go to that in detail. We started getting Myers, and because of this placement of the prisms, we started getting Myers, and by appreciating the kind of Myers that we see, we can understand that everybody is doing it right. Okay, so we know we want the pressure, we have regulated the area is in our hand, and we now are regulating the force by inserting these two prisms. Just because of these two prisms, we can say that everybody is exerting the same amount of force, which means if I go to US versus UK versus India, everybody will say that my IOP is this much, rather than a variation of one country from the other. Or if A is examining me, then B is examining me, then both of the measurements are going to be the same. It is just because of the fact that there is something which tells us that the force we are exerting is the same. Fine. Now this this is a slit lamp. I mean, I'm just trying to tell you how the applanation tonometer, here the applanation tonometer is situated here, whereas when you look at this is the applanation tonometer. This is more common. The Hagstraight type is more common. And then the applanation tonometer has many parts. Sorry, this is the main applanation which touches the eye. This is the biprism, main biprism. And then we have this weight here. I mean, this is the one which helps us to exert more and less pressure. So this is the knob which controls the amount, more and less force. So this is the knob which basically controls the force which we are exerting in the cornea. This is the housing unit. The entire black one is the housing unit, and this connects to the slit lamp, this rod. Fine. This is how the applanation tonometer looks like. And whenever we examine, we see the patient. We have these lights, so many kinds of lights in the slit lamp. We usually make the slit lamp to blue light and highest illumination to examine the patient after staining the patient's eye with fluorescent. Why do we stain the eye with fluorescent? Because fluorescent will absorb this blue light and emit a green light, and this green light will tell us whether which we will be seeing subsequently, whether the amount of force we are applying is right or not. The reflection will show us something, and that will tell us about the amount of force. Now, this is how it looks like. Okay, so what are the steps? What do we do? First, we explain the procedure to the patient that we are going to check the intraocular pressure, which is the most important, and then we instill a drop of anesthetic drop so that the patient doesn't feel the touch of any instrument in the eye. Then we stain the eye with, this is a fluorescent strip which is orange in color. We stain the eye with a fluorescent strip, and then after staining the eye, we adjust the knob somewhere between 10 to 20, 1 to 2, somewhere between 1 to 2, and we ensure that the knob is adjusted, and then we ensure that the color of the light is blue, and then we tilt the biprism in a way that it faces the eye. And then what do we do? And then we see inside the biprism with one eye. Remember, it's always one eye. This test is always done monocularly. So with one eye, we see through the biprism, and when we see something like this is visible to us, and we take it gradually, we take it towards the cornea. And from side, when we see that it's touching the cornea, we then look through the slit lamp, and when we look through the slit lamp, I was talking about, we see something like this. Why do we see something like this? It is because the fluorescent strip which we have given has absorbed the blue light and is emitting the green light. And this green light should ideally form a circle, because the circle is actually touching the cornea. But since we have biprisms inside, it splits that circle into two semicircles which are known as Meyers. So there is formation of Meyers because of the fact that the applanation tonometer absorbs the blue light and emits the green light. By appreciating the kind of Meyers, we can tell whether the force is same or different. So that's how every person is going to measure the same IOP. Why? Because it's the Meyers who speak for us. Now this shows that we are pressing it too much. This shows that we need to give some more force, and this shows that we are giving appropriate amount of force. Why? Because the inner edges of the Meyer touch each other. When inner edges of the Meyer touch each other, we say that the force we are exerting is appropriate. When they are away from each other, the force is less. When they are completely overlapping each other, then the force is very high. And again, we can also get, so this is the right measurement, the inner surface of the Meyer touching each other. So as I said, whether you are measuring in US or UK or India, if you are getting this, it means the force is same in US, same in UK, same in area. So the IOP is going to be the same because area is constant. And now this says that the force is also same in by every doctor. So the pressure is going to be the same. So this we have to do properly if we want to get a right IOP. Now here the pressure is high, here the force is high, so we have to lower the force. Here the force is low, so we have to increase the force. Now how do we lower the force? By taking the prism a little back. How do we increase the force? By taking the prism a little forward towards the cornea. And here this is another finding, we get a thick line. That is because of more staining. If we give more fluorescent, then we may get a thick line. Again, thick line will give a false low IOP, and if we get a thin line, that will unnecessarily give us high IOP. So the thickness of the line should also be appropriate. And how will that happen? That will happen when we are staining it properly. Fine. Now there is another, as I said, that in modified invert fixed law, there is one thing that was skewing the finding, and that is the surface tension and the corneal rigidity. Again, we have done it in the research level, we have done it, and now when we are doing it in the OPD setup, that thing doesn't exist. But there is another thing that exists, and that is the corneal thickness. Why? Because when we are measuring the IOP with applanation, there are so many assumptions. What are the assumptions? The assumptions is that the cornea doesn't have any rigidity, cornea is a perfect sphere. There are so many assumptions which we are taking. And because of varied corneal thickness, if the corneal thickness is more or if the corneal thickness is less, then the IOP can be skewed. If the corneal thickness is more, there will be an overestimation of IOP. If the corneal thickness is less, there will be an underestimation of IOP. That's why we also need to know the corneal thickness after measuring the applanation if we want to ensure that the finding that we have got is accurate. A 540 nanometer of corneal thickness is considered as the accurate measurement. Okay, and if the measurement is more than that, we will get a false high reading, and if it is less, we will get a false low reading. And how do we know how much high and how much low we are getting? Well, there is a calculation for it. For every 10 millimeter rise in the central corneal thickness, there will be 1 millimeter false high estimation of IOP. So, for example, we are measuring. For example, if somebody's this thing is 620 nanometer, which should be 540, then what is the gap? The gap is 80 nanometer. And if the gap is 80 nanometer, it means there is an overestimation of IOP by 8 millimeter of mercury. If the IOP is higher by 80, if the central corneal thickness is 80 nanometer high, then there is an overestimation of IOP by 8 millimeter of mercury. Okay, so that's how we get the variations. Now, its brother, as I said, its brother is Perkins tonometer, and the Goldman applanation and Perkins tonometer principle is exactly the same, apart from the fact that it looks something like this and it's a handheld device. And the third one is the Drager tonometer. Again, the same principle, but the prisms inside it is different, but otherwise the principle is the same. This is the third applanation tonometer. Now the fourth and the fifth applanation tonometers, the pulsar and the ocular response analyzer, both of them are non-contact tonometers. In that way, both of them are the same, but the pulsar measures the IOP only, whereas the non-contact tonometer measures the IOP, the corneal biomechanics, and so many other things. And here the complexity is low, and this complexity of the reading is high. And since the complexity is low, the accuracy is also low. We don't get a very accurate results, and here the accuracy is high. That's why it's used for screening, and it is more confirmatory. And this is how the NCT looks. And since both of them are non-contact, they can be used in situation where there is infection or in post-operative patients. And this is how the NCT looks like. This is a very common device which is used in most of the clinics. And this is not very common. This is an ocular response analyzer which is present in few clinics. Looks more complex, right? Now, the concept of applanation is over. The concept of indentation is over. What was the third concept? The third concept is the concept of rebound tonometer, which uses some rebound technology, which is based on some magnetic field. Basically, the technology is a rebound. We don't have to go into the details, but it uses rebound technology based on some magnetic field, because of which we get the IOP. And this is popular because it is a self-measurement tonometer, home tonometer. If a person is having raised IOP and the person wants to check their intraocular pressure regularly and doesn't want to or cannot visit the clinic very often, then this is going to help the patient. But here we have to ensure that the patient is not putting any anesthetic drop in the eye, otherwise the patient may injure his or her own cornea. Because once the cornea is anesthetized, we won't know, we may injure because we won't feel any sensation, right? So this is what it is. So this is the rebound tonometer. Next is the dynamic contour. The next technology is your contour change tonometer. That is the dynamic contour change tonometer, which changes its size and shape, everything. It changes its size and shape according to the cornea, and this is helpful in clinics like LASIK, like wherever the patient is undergoing any refractive surgery like LASIK, where the corneal thickness has been modified, any other refractive surgery. This is helpful, and this device is mounted in the slit lamp, and we have a digital tonometer which gives us the reading, and we take the measurement. Now Dighton tonometer. Dighton tonometer is again same as the applanation concept, but just that it's used transpalpabrally, again decreasing the chance of infection transmission, and this is how it is being done. And OCT tonometry is something which is under research, so we will not go into it. So I hope you enjoyed. As I said, the intraocular pressure is measured by tonometry, and among the tonometers the most popular is the applanation technique, and among the applanation the most popular is the Goldman technique, and that's why you have to know A to Z about it. But the brother of Goldman is the Perkins and the Dighton. The Perkins and the Drager. And two non-contact in applanation are the NCT, Pulsar and the ocular response analyzer.